we're going to get started. Thank you for those folks who are here in person. We're also being joined by many individuals virtually. So excited to bring to you today our usually every 6 months Hot Topics event in MS. So I'm joined today by several of my colleagues. I'm Dr. Jackie Nicholas, and I'm an MS specialist, and I direct the MS Center. And then we'll have Dr. Paige Sutton, who's our newest MS specialist that joined our center within the past year. And she is kind enough to be joining us live from her vacation on a beautiful beach. I don't think she's going to show us that, though. And then she'll be talking about MRI and MS. And then we're joined by our two expert MS nurses, Sarah Best and Ashley Thompson, and they're going to talk about untapped resources to help with MS symptoms. And then Dr. Andy Smith is going to talk to us about the advances with Epstein-Barr virus and multiple sclerosis. And then we'll have time for a Q&A and closing. So for those of you who are in the room, you are more than welcome to ask questions throughout the event or to save them until the end of the Q&A. And for those of you who are online, please feel free to type your questions into the chat as we go along, and we'll certainly make every effort to address those. All right, and I'm going to go ahead and turn it over to Dr. Paige Sutton.
Thank you, Dr. Nicholas. I'm so glad to be here with everyone today, and today to be talking about a very important topic in MS, and that is MRI imaging. And if you have MS or you know someone who has MS, you're probably pretty familiar with MRIs, but they're magnetic resonance images, and we use them very frequently, both for the diagnosis and for monitoring of MS. And there's a lot we could talk about with MRIs, but I'm going to focus on 3 different areas. And the first is how we expect MS to look on MRI. So we're going to go through different sequences of MRI and see how we would expect MS lesions to look on different sequences. Then we're going to look at some radiology reports and try to understand how can we understand the language in a radiology report and make it make sense to us personally. And then finally, looking at some updated imaging guidelines for MS that came out last year. So first, looking at the MS appearance on MRI, we'll start with T2 and FLAIR sequences. And these are together because both T2 and FLAIR MS spots are going to look the same, and that's that they're going to look bright. So you'll hear the term hyperintense lesions, which just means bright spots. So this is an example of a FLAIR image, and that stands for fluid attenuated inversion recovery. And basically, the MS spots are going to be bright on this image. So here they are. And this is in a sagittal plane, so that's shown here. So this is the front of the head, and this is the back of the head. This will be where the eye would be. And then this is where the lateral ventricle will be if we go one slice over. So this pattern is a pattern that you may have heard about before and is pretty classic for MS, and that's called Dawson's fingers. So these are spots that are oriented perpendicular to the lateral ventricle, and they look kind of like little fingerprints. So this is a classic spot for MS to affect right next to the ventricle. Other classic spots that we use in the diagnosis of MS would be juxtacortical, meaning right next to the surface of the brain, infratentorial, in the lower part of the brain or the brainstem, and then also spinal cord, which we will get to. So the next sequence is T1, and on T1, you may have heard of something called T1 black holes. So these are some examples of T1 black holes, and these on a radiology report would be referred to as hypointense lesions, just meaning that they're darker. So what T1 black holes represent is a more chronic stage of MS spots where there's destruction of this white matter of the brain. And this is usually indicates irreversible damage. So you can think of these as little scars in the brain. And this is just a different orientation of the MRI. So this is called axial, where this is the front of the head and this is the back of the head. And so these are examples of hypointense lesions. If we look at T1 image with contrast, so after IV gadolinium contrast is given, some of MS spots might light up with contrast, and you may hear them referred to as contrast-enhancing lesions. So this is a different view called coronal, where this is actually the left side of the brain and this is the right side of the brain. And these are those lateral ventricles. And this is an example of a lesion right next to the ventricle that has contrast enhancement. And this is in an open ring pattern, which is very classic for MS or demyelination. And this open ring can be used to help us differentiate a contrast enhancement pattern from something else that may mimic MS but may have a different pattern of enhancement. And usually this enhancement will be present for a period of weeks. In some more rare cases, it can be up to months, but typically we expect contrast enhancement to be present for weeks. So if an MRI is done and there's contrast enhancing lesions, that tells us there's active inflammation that is new. Now looking at a spinal cord MRI, this is also a T2 sequence. So just like in the brain, we expect the lesions to be bright or hyperintense. And here's an example of a sagittal image of the cervical spine. The upper spine does have some thoracic in it as well, but we can see this bright spot in the upper cervical spine. And when we look at it in a cross section on an axial view, we see that it's involving the peripheral cord. So, and this is classic for MS because MS affects the white matter, which is in the side of the spinal cord and the back of the spinal cord. So usually the spots from MS will be in the peripheral cord. And these lesions in the spinal cord will also have contrast enhancement if they're active. So now we're going to look at some examples of MRI reports to try to understand some of the terminology used. And when you get an MRI report, there's usually a lot of information. It can be overwhelming because the radiologist is going through the whole image and they're commenting on things aside from MS. So you'll see in the findings, the radiologist is mentioning looking for things like infarct or stroke, looking for bleeding. They're looking at the overall structure of the brain. And then what we really want to pay attention to, at least at first, is the impression, because this gives us an overview of what the radiologist found and thought was important. So looking at this impression, we see the radiologist mentioned that there's multiple T2 flare hyperintensities. So that means the bright spots on the T2 flare sequence, and that these were in specific regions. So periventricular, meaning next to the ventricles, pericallosal, meaning next to the corpus callosum, and the corpus callosum is the area of the brain that connects the two hemispheres, also a classic spot for MS to affect, and juxtacortical, meaning next to the cortex or surface of the brain. The radiologist also commented that there's no evidence of pathologic enhancement. So that means we're not seeing any active inflammation or new spots, at least in the last few weeks. So, as an example of some of these images associated with this report, these T2 flare hyperintensities in the periventricular region, here's one of them. So here's the ventricle, and here's this T2 bright spot next to the ventricle. Actually, it's flare, bright spot. And then here's the lesion right next to the cortex. So this is the juxtacortical region. So this brighter part of the brain is the cortex. And you can see this is right next to it. So here's another MRI report. And here, the radiologist also comments there's white matter signal abnormality in a distribution typical of a demyelinating process such as MS. And when we look up at the findings, that white matter signal abnormality they're talking about is the same T2 flare signal intensity in these certain regions. So this MRI shows some of these white signal abnormalities, and you can see these bright spots right next to the ventricle. So these are periventricular lesions. And then the radiologist also commented that there was a single enhancing lesion. So here's a T2 flare image, and you can see that this lesion here on the contrast image has this kind of ring enhancing contrast. And here it is zoomed up to show you that it is a ring enhancing pattern. So that's typical of a new inflammatory lesion. So if this was present on a new scan or a follow-up scan, we may be talking about acute treatment with steroids, or we may be talking about changing disease-modifying therapy, depending on the case. So here's an example of a report of a cervical spine MRI, where the radiologist comments there's abnormal signal involving the upper cervical spine and the brainstem, compatible with MS. So here's the cervical spine image from a side sagittal view. You can see the arrows are pointing to these two bright spots in the upper cervical spine. Here's an example of one of them from an axial view, where you can see it's mostly involving the posterior spinal cord where white matter is. And then there was no associated enhancement, so neither of these lesions was new, indicating active inflammation. You can see that here on the T1 post-contrast image that we don't see any bright spots on the post-contrast associated with these. So now I want to look a little bit into the updated imaging guidelines. And there was an updated consensus guidelines published last year by 3 different organizations, committees. And these were MAGNUMS, which is the Magnetic Resonance Imaging and Multiple Sclerosis Study Group, CMSC, the Consortium of Multiple Sclerosis Centers, and NAMES, North American Imaging and Multiple Sclerosis Cooperative. And the purpose of these guidelines was to combine the knowledge of these groups and all of the updated research findings into clinical use, so that we had uniform recommendations that all MS providers could use to help us determine when MRI should be used, both in the diagnosis and for monitoring of MS, and also when we should use things like contrast. So we'll talk about 3 parts of these updated guidelines that I think are most clinically relevant to us. And the first is the timing of MRIs. So when should they be done in terms of diagnosis and follow-up? The use of contrast. And this is important because we have discovered that contrast can kind of accumulate in the brain. And clinically, we don't know if it's harmful. But in order to be safe, the recommendations have changed to limit the amount of contrast we're using when it's possible to and when it's safe to do so. And then we'll talk a little bit about MRIs during pregnancy and whether those are safe. So looking at timing of MRIs, so we'll start at the beginning, which is the baseline imaging. So when someone comes in and there's concern for MS, we always get these baseline images to look and see if things are consistent. So with baseline imaging, we get imaging of the brain and the spinal cord, so cervical and thoracic spine. And the reason for that is because it can help us to evaluate the burden of disease and can also help us to make a diagnosis. So you've probably heard of dissemination in time and space as part of the diagnostic criteria for MS. Dissemination in space is represented by having 2 of 4 specific regions involved. And 3 of those are in the brain, but 1 is spinal cord. So having the spinal cord imaging can help us to make the diagnosis in a lot of cases. Contrast is recommended in baseline imaging because that can also help us to make a diagnosis because if there is contrast-enhancing lesions as well as non-enhancing lesions, that tells us that there's change in time because there's both active and not active spots. And it also can tell us whether the MS is active at that moment. So if there's a lot of contrast-enhancing lesions, that tells us there's ongoing inflammation and tells us we really need to start treatment quickly. So after a diagnosis is made and someone started on a disease-modifying therapy, or in the future, if the disease-modifying therapy is changed to something different, we always want to get a new baseline image. And so 3 to 6 months after starting any new disease-modifying therapy, it's recommended to get new baseline images. So this includes at least the brain. In some cases, we might include the spine too, depending on the specific case. For example, if someone had a lot of disease in the spinal cord, we may want to get another baseline spinal cord image to compare to in the future. And with these images, contrast is not required, and that's because this is used as a baseline to compare future scans to. So when we look at future scans, we're going to be comparing the T2 bright spots we're seeing here to see if any new ones pop up. And so the reason we wait 3 to 6 months to get this after starting a new disease-modifying therapy is because some of them take time to become fully effective, and we want to make sure that this is a true baseline image while the medication is in the system doing its job. And then in the future, we can compare future images to this to see if the medicine's really doing its job and preventing new spots. So then we have imaging that we do every 12 months while on treatment. And this includes, the recommendation is just to do the brain every 12 months. And that contrast is not required because, again, the purpose of these scans is just to look for new activity, and contrast doesn't tell us anything different than this T2 or flare sequence would by looking for new spots compared to the baseline. So we can just compare them side by side, and contrast is not necessary. So now we're going to look at a list of scenarios where we might want contrast and where it's not necessary to get contrast. And this is not going to be a comprehensive list, but we'll summarize the most common clinical scenarios. So contrast is needed in first ever baseline MRIs, like we just talked about. And that's because it can show us active enhancement. It can help us to confirm a diagnosis and also to differentiate MS from other diseases that can also cause white spots on the brain. And another scenario where contrast is needed is if there are new symptoms that are concerning for an inflammatory relapse. So not just any new symptoms, but specifically new symptoms that we can localize to a certain part of the brain or spinal cord that lasts more than 24 hours consistently, and that are not because of an old MS spot causing flare-up of old symptoms, which is sometimes referred to as a pseudo-relapse. So when someone comes in with new symptoms and we're concerned about an inflammatory relapse, we do like to get imaging with contrast, because if there was an enhancing spot, that could tell us that there was new active inflammation and could help us to guide management. Contrast is not necessary in the monitoring MRIs like we just talked about, because we're comparing side by side and looking to see if there's any new spots, and contrast doesn't add any new information to that. It's not needed with new baseline MRIs after we're switching disease-modifying therapy or starting a new disease-modifying therapy, except in very specific scenarios. And it's not necessary with monitoring for medication safety. So specifically PML, progressive multifocal leukoencephalopathy. We do yearly scans. It's the same yearly scan that you would get to monitor for MS activity. And contrast is not necessary. If we were to see something that was concerning for PML, that may be a case where we would go back and add contrast, but just in the monitoring for PML, it is not necessary or needed. And then finally, during pregnancy, so MRIs are not contraindicated during pregnancy. We don't have any evidence to suggest that there's an increased risk of stillbirths, neonatal death, congenital anomalies, or cancers in babies who are exposed to MRI in utero. But this decision is made on a case-by-case basis. So we do weigh the risks and benefits of everything we do in medicine. When it's necessary to get an MRI during pregnancy, we do like to use an MRI with a lower field strength of 1.5 Tesla, and that's the strength of the magnet. And that's important for us because we do have a couple of locations within Ohio Health that use a higher magnet strength of 3 Tesla. So in cases of someone getting an MRI during pregnancy, we would make sure to send them to one of the facilities that uses a 1.5 Tesla. Gadolinium contrast is contraindicated, meaning we do not use it during pregnancy, and that's because it can cross the placenta and baby can be exposed to it, and there has been some complications associated with contrast getting to the fetus. So it is contraindicated to use contrast during pregnancy. However, immediately after giving birth, MRIs are permitted and contrast can be used even in those who are breastfeeding if necessary. So here are some references, and now I would be happy to answer questions through the chat or in person if we have time, or at the end of the presentation. Thank you all.
Thank you, Dr. Sutton. That was an excellent overview of MRI in MS and makes it really clear. One of the questions that sometimes people with MS will ask is why we monitor the just with the brain MRI annually. People will say, you know, I have a lot of lesions in my spinal cord, but we're not getting that annually. And could you speak to that and why that is?
Absolutely, and that is a question that does come up in the clinic a lot, so I'm glad you asked that. So the MRIs for monitoring, the reason we're only getting brain is that it is much, much more common to have lesions in the brain that are subclinical, meaning they're not causing any symptoms. So we are much more likely to pick up subclinical activity on a brain MRI, which is why we're getting them done once a year. That's compared to spinal cord lesions, where if you have a new spinal cord lesion, you're much more likely to have symptoms. And so if someone came in with new symptoms that were suggesting a spinal cord lesion, we would of course get imaging of the spinal cord at that time and with contrast, but we wouldn't normally do them for the routine imaging. There are specific scenarios where we would add it for routine imaging. For example, if someone had progression that could not be explained by their MRI changes of the brain.
Thank you. That's incredibly helpful.